Hi, everyone. I am recording this short lecture just focusing on sinus rhythm. So we'll have regular sinus rhythm, normal sinus rhythm, just sinus rhythm we call it, sinus bradycardia, and sinus tachycardia. It'll be a fairly short, but I hope interesting opportunity to talk about these rhythms. We've looked at this before, and it's just important that we remind ourselves again that the sinoatrial node or SA node normally depolarizes faster than any other part of the heart's conduction system. So normally the SA node is the heart's primary pacemaker, right? You see it up there on the left in the left of your screen in the right atrium. And as a result, it's important to recognize then that when the SA node is firing within the normal range, which is 60 to 100 beats per minute, typically we have a cardiac output that is sufficient to manage all of the activities that a person needs to be involved in physiologically. There are lots of conditions that can affect that and lots of things, underlying conditions that can cause our heart rate to either accelerate or decelerate, and we'll talk about them as we move our way through this next little bit. Just a reminder that a person's heart rate varies with their age. In this course, we just talk about adults, but in adults and adolescents, the SA node normally fires between 60 and 100. Often now we're talking about 50 to 60 as that gray zone. That may or may not be an issue. It may be a sign of a heart that's functioning very well and is as well adapted. It may be a sign of other things, and we'll watch for that. Okay, sinus rhythm, how do you recognize it? And we're going to go through this systematic approach. If you haven't watched the video on systematic approach, so important that you take a look at that. But what we see here is sinus rhythm. And what I can see just with a quick look at this, sinus rhythm about 80 beats a minute with ST segment elevation. And I hope many of you are saying, yep, that's what I see. And maybe some of you are saying, what? But we're going to work our way through all of this. So remember, sinus rhythm, the name says it all. That's the name we given to a normal heart rhythm. It's sometimes called regular sinus rhythm, sometimes called normal sinus rhythm, just called sinus rhythm as well. And that represents normal electrical activity, right? So that conduction that is initiated at the SA node heads down through that normal conduction pathway through the atria, stops at the AV node, and just sort of gathers up steam, and then down through the bundle, the right and left bundle branches, and the Purkinje fibers. And a rhythm, if you look at this little box at the bottom, a rhythm that begins in the SA node has the characteristics listed here. So it has a positive or upright P. So the deflection is upright from that isoelectric line. And it has that positive upright P prior to every QRS complex. So we see a P prior to every QRS. And the P waves all look alike. P to P to P to P, they all look alike. They don't vary. There's a constant PR interval, and that PR interval is between 0.12 and 0.20 seconds. And that we measure that beat to beat, it's always the same. And there's a regular atrial and ventricular rhythm. So P to P to P to P to P is the same. Q to Q to Q to Q to Q, or QRS to QRS, whatever. That R to R to R is all the same. Right? So when we're measuring, it's all the same. Our QRS duration is 0.11, or remember we've said it could be 0.12. A little box doesn't, there's always that forgiveness of a little box, but so you'll see some references say 0.12. In any case, less than that, 0.11 or 0.12 is what we expect for our QRS. If it's wider than that or longer than that, that tells us that there is a delay in the conduction. Now, it's important also to recognize that sometimes electrical impulses that begin in the SA node can be affected by a variety of things. Medications are one of them, diseases, or conditions that cause the heart rate to speed up or slow down, or even beat irregularly. Sometimes there are diseases or conditions that delay or block the impulse from leaving the SA node, or diseases or conditions that prevent an impulse from being generated in the SA node. And so let's move on and keep finding things that are of interest. So we talked about sinus rhythm, normal sinus rhythm, regular sinus rhythm, 60 to 100, and all those criteria. Now let's talk for a minute about sinus. If the SA node fires at a rate slower than normal for the person's age, the rhythm is called sinus bradycardia. So the rhythm starts still at the SA node. The place of origin doesn't change, but it travels down the normal conduction pathway and it results in atrial and ventricular depolarization. In adults and adolescents, a sinus bradycardia has a heart rate less than 60. And remember, we sort of think 50 to 60 is a gray zone, but we still call it a bradycardia if it's less than 60. And we call it a severe bradycardia if it's less than 40. So let's look at a strip here. What do we see? Here we've got a sinus bradycardia at 40. How do I know it's at 40? Do you remember we've done a variety of different counting methods? If a strip shows a rhythm that's irregular, we have to do it, we have to count by a 6-second strip. If we've got a regular rhythm, and we would measure that doing our P to P to P, R to R to R, if that is a regular rhythm, we can do a variety of methods for counting. We can count using the small box method, so divide the number of small boxes by 1,500. We can do a large box method, divide that by 300. Most nurses in practice will do exactly what we talked about in class, which is that countdown method. And it typically, you would start with whatever complex you find that lands on a heavy line and count down by that sequential method. And the counting from big heavy line to heavy line would be 300, 150, 100, 75, 60, 50, 42. Now, once you get below 50, you're typically not doing that count any longer, but let's see. Now, I would actually, if I was in practice, I would mark off on a little piece of paper or use my calipers that distance from between an R and an R. And then I would put it on a heavy line. So I'd move, see how the first QRS complex is just one little box over from that heavy line? I would move my little paper mark or my calipers over there so that I could measure and do my countdown. So I've moved it over, let's say to that, to the line just preceding that heavy line, just preceding that QRS. And let's say I'm going to do my countdown. So 300, 150, 100, 75, 60, 50, 42. And then I've got a couple of little boxes. And I'm so sorry, that's my dog in the background who thinks she's ferocious. So ultimately, my rate is about, oh my gosh, I'm so sorry. My rate is about 40. But otherwise, and my QRS is within normal limits. It's less than 0.11. Remember, we start at the beginning of our Q, and we stop measuring when we start to see a horizontal line. Sometimes it's hard to see where you stop measuring. But in this case, as we come down, we have a small Q, come up to a big R, come down to S, and then that ST segment starts almost immediately right there. See where you have that tip down there? And so the QRS is just those, let's see, 1, 2, just 2 and a little boxes. And so as it starts right down from that lower point tip, that's where you end that QRS. And as it's somewhat horizontal moving across, that is your ST segment. So what causes sinus bradycardia? For many of us, particularly children, but even in adults, as we sleep and become profoundly relaxed, our heart rate goes down. We talked about conditioned athletes. Up to a third of people under 25 will have a lower heart rate. Sometimes it's abnormal with some particular conditions, an MI, an acute myocardial infarction, particularly an inferior MI, it's very common in. Also, we see something now later on, we'll talk, oh gosh, I'm so sorry. Later on, we'll talk about how we can use vagal stimulation to actually help us in situations of a sinus tachycardia or other tachycardias to try to break that cycle. But vagal stimulation that happens in other ways can be a problem for people. So you may have a coughing episode, a vomiting episode, a patient straining to have a bowel movement. And when they do that pushing, that can either be intentional, like I'm pushing to strain to have a bowel movement, or I'm just coughing or particularly vomiting. You can have patients who have that stimulation of your vagal nerve. That vagal stimulation causes a stimulation of your parasympathetic system, which is the rest and relax system, particularly impacts the both atria and that causes that decrease in heart rate. There's also sudden exposure to cold water, and we can sometimes see that also that what we call the amphibian response, stopping to breathe, and that sudden drop in heart rate when children in particular are submerged in freezing cold water, like if you fall into a river. Carotid sinus pressure, that's pressure that's placed on your carotid sinus. We used to in the past, again, use that therapeutically to try to help in situations to lower rapid heart rates. What we find now is that there's so much trouble with a patient's carotid that we may induce a stroke by breaking off some plaque. So unless we have a really good understanding of the status of their carotid arteries, we would typically not move forward with that as often as you would have seen in the past. So what kinds of things in general can we talk about that cause bradycardia, sinus bradycardia? If we have a problem with the SA node, remember we said there's certain diseases that can affect the ability of the SA node to generate an impulse or to have that impulse leave the SA node. High or low potassium, critical that we watch that. Hypothermia is a really important one, that when adults experience hypothermia, one of the things that happens is our body heart rate slows down as our core temperature decreases. Low thyroid, so hypothyroidism or lack of oxygen, really important. As our intracranial pressure rises, our heart rate goes down. I talked already about inferior MI and sometimes posterior MI, but inferior MI, it's a really classic sign. We give some medications that are intended to control our heart rate, and sometimes they bring that heart rate down to a point that it's actually a bradycardia. So things like calcium channel blockers, digoxin, beta blockers, amiodarone, and sotalol are really important ones. If we have sleep apnea, in particular that obstructive sleep apnea, heart transplant patients will see that you're not going to probably look after heart transplant patients unless you work on a multi-transplant unit where you would have many indicators for rhythms. And again, that vagal stimulation that we talked about that we'll also use in a therapeutic way. So what do? If a patient has no symptoms, if they're an elite athlete walking around or somebody who's sleeping, then we're not going to treat that, right? The patient is fine and well, and it's just an anomalous finding, but it may be the patient's normal or the normal in the moment. However, if the patient is symptomatic because of that slow rate, let's start by applying pulse oximetry. We want to see what their O2 sat is. And we would also always think first to give supplemental oxygen. Why would we do that? Because we're always thinking any aberration in our cardiac conduction system may influence the cardiac output of our heart and the ability of our heart to nourish itself. So we always want to be applying oxygen early. We're going to start an intravenous to make sure that we can give medications or do resuscitation if needed. And we're also going to do a 12-lead ECG. A lead 2 strip provides us with a tiny snapshot, and what we want is that 12-lead ECG, which gives us a better picture. We can, if it's a profound bradycardia or bradycardia where a patient is symptomatic, we can give a medication called atropine. Atropine is called a vagolytic, which means it like snips the impact of the vagus nerve. We give that drug intravenously, and that's the drug of choice for symptomatic bradycardia. You'll see results very quickly. We want to reassess the patient and continue to monitor the patient once their heart rate comes up. Atropine is most often a very effective drug. If there's other things going on, we would move beyond it. I don't want to get it too much into detail because a sinus bradycardia, as opposed to a heart block or something else, typically is very responsive to atropine. So let's talk about that just for a second. It's a vagolytic, and we use it to increase your heart rate. And so when you think of a vago, what we really think about are that vagus nerves, the right and the left vagus nerves, main nerves of the parasympathetic system. And lytic means to interfere with. So this interferes with the effect of the vagus nerve. Atropine blocks the chemical at the ends of the vagus nerves. And so that allows more sympathetic nervous system activity. And as a result, the rate at which the SA node can fire is increased. It also increases the rate at which impulse conduction moves through the AV node. Remember, it stops there and gathers up speed, and this actually decreases the amount of time it stops to gather up speed there. However, it's important to recognize that atropine has little or no effect on the force of contraction. It's just that speed of conduction. Hey, look, we've done 2 already. Now let's talk quickly about sinus tachycardia, and I know you're going to know this. So what happens? Remember, we talked already about this, that the normal heart rate varies with age, and in adults, the rate associated with sinus tachycardia is usually between 100, like just over 100, 101, and 180. Rare to see a sinus tachycardia that high, maybe 150 even. It's rare. It can go up to 180, but it's rare. Because infant or children's heart rate can transiently increase during things like crying and pain or fever, the term tachycardia is one that we use to describe a significant and persistent increase in heart rate. And that's really important. So when we look on a monitor, it looks like sinus rhythm, but it's going to look faster. At very fast rates, sometimes it's hard to tell the difference between what's the P wave and what's the T wave because they sort of jump on each other. And you'll see on this note here that it says the QT interval is shortened. Don't worry about that. At higher levels, we'll be talking about QT intervals, not here. So not to worry about that. That's a calculation. You might see that on a 12-lead ECG, just so you know. So here we see sinus tachycardia, and how do we recognize it? First of all, we look P to P to P to P, is it all regular? R to R to R to R, is it all regular? And again, I can use my calipers, or I can use my piece of paper and mark it off and move it along the strip, and is it regular across all of them? Then I am going to figure out what is the rate. And I would figure out the rate both for the atrial rate and the ventricular rate just to make sure it's the same. Do you remember I just talked about that counting method? Let's see if we can find one that is just on a solid line. Okay, it's pretty close. So if we look at the 3rd beat from the end, so all the way down the strip to the 3rd beat from the end, that's pretty close to landing right on that solid line. Let's do that sequential counting down method, right? So from where that is, that R, to the next heavy line, 300, 150, 100. Okay, this is between 100, which is less than it, and 150 that is more. Now, would I just say it's between 100 and 150? Not really, because there's a huge difference between somebody having a heart rate of 102 and someone having a heart rate of 147. So how would I know? Remember, we've got 300, 150, 100. I know it's between 100 and 150. But how do I know how far it is? Well, if you look at those little boxes, there's 5 little boxes between those 2 lines, those 2 heavy lines. The difference between 100 and 150 is 50. So each one of those little boxes is worth 10. So remember, there's 5 boxes that make up the difference between 100 and 150 when we're doing that sequential method. So each little box is 10. Now, if we were doing different rates, those little boxes would be worth different amounts, but here it's going to be worth 10 in this segment. And so we would count. So if we start at 100, 110, 120, it's not quite 130 because I see this, the first beat was just a little bit off the line. So it's about 125. So it's definitely a tachycardic rate. Let's look at our P waves. They're all positive. That means it's an upward deflection. And that there's a P wave, they all look the same, and there is a P wave in front of each QRS. And when we look at our PR interval, it should be between 0.12 and 0.20, and it is. We look at our QRS, and we see that our QRS is also less than 0.11 or 0.12. And so we have a sinus tachycardia at about 125. So what kinds of things can cause sinus tachycardia? It's often a normal response to your body's demand for more oxygen. And that results from a lot of things, right? So lots of times patients can really tell you my heart is racing, and they can really sense that increased heart rate. And some patients will actually talk to you about palpitations or a racing heart, feeling of pounding in their chest even. Sometimes when patients have more significant underlying conditions like acute MI, or particularly when we're looking at tachycardia, an anterior MI, we'll see this. Some patients with coronary artery disease will experience sinus tachycardia, and that can cause real problems because in a situation like that, your heart's demand or requirement for oxygen increases as the heart rate increases. And as the heart rate increases, there's less time for the ventricles to fill and less blood for the ventricles to pump out with each contraction. And that leads to a decrease in your cardiac output, right? So less time for the ventricles to fill. So there's less blood in the ventricle with each contraction that you're actually contracting and pushing out into circulation. And so you have a drop in your cardiac output. And also, because the coronary arteries fill in diastole when those ventricles are at rest, rapid heart rate decreases the amount of time available for that filling, and it decreases the heart's blood supply. So chest discomfort, chest pain can be a result of that because of that decrease in blood supply to the actual myocardial cells. So tachycardia in a patient who's having an acute MI may be an early warning sign that heart failure is impending. We may also see that cardiogenic shock is impending and more serious dysrhythmias. But when we talked about those early things, or common things in life, exercise, fear, pain, fever, very common. I say for me, it's caffeine. If you were in class, I talk a lot about how much I drink caffeine. One day I'll be mortified that I admitted to that, but really it's so ridiculous that I drink so much coffee. In any case, can increase your heart rate. Hypoxia, again, hypoxia can cause a bradycardia or a tachycardia. Hyperthyroidism, remember we talked to sinus bradycardia, we talked about hypothyroidism or low thyroid levels. High thyroid levels can cause a tachycardia. Other kinds of drugs, sympathetic stimulation, and things like shock or other things where your body isn't moving to compensatory mechanisms. So what do you do for sinus tachycardia? Treatment, just like a bradycardia, is directed at correcting any of the underlying causes, right? So do we need fluid replacement? Is a person dehydrated or they're in shock and they've lost, if they have a fluid volume deficit? If the sinus tachycardia is caused by pain, what are we doing to relieve pain? Do we remove the offending medications or substances? So if it's toxic substances, if it's some kind of toxic ingestion like street drugs, other things like that. If it's fever or anxiety, are we reducing whatever's causing the fever, or are we helping to mitigate the anxiety? Sinus tach in a patient who has an acute MI may be treated with medications, and that's really important because remember we talked about cardiac output is impeded with sinus tachycardia, but also it causes further damage. When someone is having an MI, we want to make sure that that we are able to get adequate oxygen to those myocardial cells. And since they only are able to receive that oxygen through that diastole or rest period, we want to both cut down on the amount of work of the heart, so decrease that heart rate. We also want to make sure that there is adequate time for filling to increase of the ventricles, to increase our cardiac output, and also that there's opportunity for those coronary arteries to have blood flow through them so that that blood can be exchanged through the capillary membranes to actually nourish the cells, our cardiac cells. It's important to recognize that if we were to give a medication to slow down the heart, like for example, a beta blocker, we would always watch first to make sure that there's no contraindication and no sign of heart failure. And that's it. Can you believe it? That was a quick and easy one. I hope that was helpful for you. And the next one to watch is atrial rhythms.